All right, we're going to wrap up chapter 19 today, part 2b, talking about just a little bit about the enzymatic aspect of tubular transport and reabsorption, and then we'll get into the final mechanism of tubular secretion. I do have a little bit of a topic to wrap up before we get into secretion, and that is to say, when it comes to reabsorption, those transporters like SGLT and some of the other co-transporters that we use for, say, secondary active transport have what is known as a saturation point. They behave like enzymes. In fact, I consider them enzymes. It's just that the reaction they're catalyzing isn't changing chemical bonds, it's changing location across a barrier that a molecule normally wouldn't pass, lowering the activation energy anyway. Well, so transporters behave like enzymes. And so we're going to start talking about this concept known as renal threshold when we hit saturation of those transporters over the next few slides. Filtration, the part of the glomerulus that with the capillaries that are fenestrated, always obey what we call first order kinetics. That is to say, there's a direct proportion of concentration in the blood to whatever makes it into the filtrate. So if something filters, it's going to filter in a sort of a linear accelerate or a linear progression as concentration increases. It's basically a one-to-one situation. The more you have in the blood, the more filters. And there is no limit here because this is a physical process. It doesn't require an enzyme or something to facilitate the lowering of activation energy. Reabsorption, on the other hand, is an enzyme-related process. That is to say, you have transporters that bring this material back into the blood from the filtrate. Now, just like an enzyme accelerates a chemical reaction, these transporters are facilitating the movement of these molecules. And when you have lower concentrations of the substrate that's carried by the transporter, we always refer to it as the plasma concentration. That's just a way of convention. But in any case, if we have a low plasma concentration, all of that material that's supposed to be resorbed is resorbed. And we see that one-to-one ratio. We see that first order kinetics right up until we hit a point where those transporters cannot transport any faster. When we hit that spot, that maximum rate of transport, I'm not going to ever ask you about TM, but it's maximal transport. That's the point when the enzymes or the transporters get saturated and they can't carry anything any faster. So it doesn't matter how much more you have in the plasma to begin with, you're not going to see any faster rate of transport. And let me give you a sort of an example, and glucose is a good reminder for me. When we do lab at the end of the year, when we're in class in person, we usually do a urinalysis, and it's a fasting urinalysis. So, usually take it right after you've woken up in the morning or you haven't eaten for several hours. When we test the urine, you don't see any glucose or very, very low, usually none. Okay. A healthy person who hasn't eaten for 6 hours or more, there should be no glucose found in the urine because the blood plasma glucose is so low, all of it gets retransported back into the blood. But let's say you go out to Long's Donuts, which sounds really good right now, and you have one of their world famous yeast donuts, or maybe two, or maybe three. Doesn't really matter. It's just a donut, right? Well, what you would see is you would see glucose appearing in the urine, even though under normal circumstances, if you're fasting, you don't see it. All of a sudden, you'll see what we call glucose spill. That's because we have hit this saturation point, and anything that is not transported because there's just too much of it, so we're transporting some of it, but there's residual left over that doesn't get transported, well, that makes it out into the excreted urine. That point where we begin to see something because we have exceeded the transport maximum is known as renal threshold. So at the point that glucose is so high in the blood that you can't resorb it from the filtrate back into the blood because the transporters are saturated, that is known as renal threshold. And so we begin to see glucose being excreted. This is the excretion rate. Excretion is that which filters, and glucose always filters in 1-to-1 kinetics. Resorption obeys 1-to-1 kinetics until you hit the renal threshold, and then you start to spill it out into the urine. That's why if you accidentally eat too soon before a urine test, or that sort of a thing, you will see unusual molecules present in the urine because you can't retransport those things back into the blood following filtration. So let's merge all three graphs in order for efficiency's sake. And again, that's one of the reasons why I want you to improve your graph reading skills, because that happens when you get into the clinic. Rather than 500 graphs, they merge most of them to make it a little more efficient, and you get used to it. But I want to accelerate that process. So we have three graphs going on here. We have filtration, okay? We have reabsorption, and we have excretion. Filtration is a physical process, so even if we had 1,000 milligrams per 100 milliliters, we would still see that line projecting in a 1-to-1 relationship. Reabsorption, on the other hand, is an enzymatic process. So we have a certain number of transporters, and we can transport it all right up until we hit the saturation of those transporters. And as soon as we hit saturation, and we increase glucose just a little bit, we begin to see glucose appearing in the urine. That's renal threshold. This is just the graphical rendition of filtration minus reabsorption plus secretion. We're not secreting glucose in this case. So minus reabsorption equals excretion. And up to 300, the reabsorption is equal to the filtration, so excretion is 0. But as soon as we hit 301, excretion becomes 1. Because we filtered 301, we resorbed 300 or so, and the remainder gets excreted. So it's just a graphical representation of what we've already talked about. Okay, moving on to secretion. This is the active process of moving material from the peritubular capillaries. I did forget to mention, by the way, it's reminding me here, is that we have a capillary bed here, then we have a convergence, and then we have a second capillary bed surrounding the tubules and the loop of Henle. This is a portal system. This is the third portal system, the first one being the anterior pituitary. The second one we didn't really talk about much. It's the hepatic portal system with the liver. And here's our third portal system in the nephron. But now we're going to work on the secretion. This is the active removal of things from the peritubular blood into the filtrate to be excreted. It is an active process. You're using enzymes, you're using energy to do this. Oftentimes it's involved in, like, for instance, acid-base regulation. So when you look at some of those figures earlier when I said acid-base pH kind of a thing, when we're secreting protons or we're regulating potassium, those mechanisms are very much at play in the secretion mechanism. Now, when we increase or we vary secretion, that's obviously going to affect how much is excreted. Okay, so if we don't filter anything, we don't excrete anything unless we secrete it. Okay, that's what that phrase means. Lastly, because it is an enzymatic process, we do have recognition of the fact that we can inhibit that process with certain molecules, and that can lead to things like drug toxicities, or it can lead to things like enhanced activity of a drug, like for instance probenecid. What happens is penicillin gets actively secreted out of the bloodstream by these transporters that we're going to talk about, And probenecid acts as an inhibitor of those transporters, which means penicillin stays in the blood longer and is more effective. So it can be a beneficial thing if you know how to take advantage of it, or it can be a potentially toxic thing if you have an issue with the transporters being inhibited as something that's fundamentally toxic. Before we get into the secretion mechanism, one of the reasons why secretion can become exceptionally important has to do with the fact that this is how we get rid of a lot of drugs or other molecules that come into our bodies, like through what we eat. When you eat vegetables and material, when you eat food, you're not only bringing in nutrients, but you're also bringing in potential bioactive molecules. And these aren't contaminants per se. This is just the natural aspect. Natural foods are going to have things that our body's going to want to get rid of. Look no further than when you eat asparagus. Okay, yeah, that's the famous one, right? If you eat a lot of asparagus, especially, your urine will take on a different odor and consistency due to the fact that your body is excreting those molecules, and it's doing it by secretion. So if you have a drug or some other molecule, it doesn't have to be a drug, maybe it's already got the right chemical components to be recognized by the kidney and excreted. Other molecules, other drugs may have to be metabolized, especially by the liver, in order to be flagged so that the kidney transporters will recognize it for secretion. So just let me give you just a quick example. So that's a conjugate, we call that a conjugated metabolite. In any case, let's start with a well understood drug called phenobarbital, very well understood drug, been around a long time. What we know about phenobarbital is that it gets metabolized by the liver and to a certain degree by the kidney, and it forms these conjugates. So here's one or here's another. And so we add these functional groups to this molecule, and now this molecule can be targeted as a conjugated metabolite for excretion. So that's the whole point of learning this next mechanism, is understanding that this is how we get rid of literally thousands and thousands of compounds without having to have thousands and thousands of transporters. We just simply have enzymes that will identify and tack on these functional groups that then flag them for removal from the body. So one of the major secretory mechanisms, particularly for metabolites that we often refer to as organic anions. Organic anions means it's an organic molecule and it's a mild acid of some kind, a carboxylic acid, maybe a metabolite of an amino acid or a metabolite of a drug or a metabolite of a lipid, that sort of a thing. Those are all organic anions. And so we use these organic anion transporters, and we're using a process called tertiary active transport. Now this looks like a bunch of gobbledygook right now, but I'm going to show you how to break this down. If you can break this down, as complicated as it might look, you can actually do almost anything when it comes to epithelial transport or drug delivery. The world is your oyster, shall I say, if you take the time to break it down carefully. So we're going to work through this mechanism slowly for you. So let's look at our kidney tubule cell. And we have an apical surface and a basolateral surface. You know, tight junctions would be right here. Let me draw those in real quick. Tight junctions are right there. They're not relevant to this module, but I'll just go ahead and put them there for you. So what's going to happen? Well, the first thing we need to do is establish a gradient of some kind. So let's establish a gradient, and we're going to establish a gradient of sodium and potassium using ATP. Pretty straightforward. That's primary active transport. We're hydrolyzing ATP into ADP and PI, pumping 3 sodiums out for every 2 potassium. So we're going to have high potassium in here, high sodium, low sodium. Okay? Now we can use secondary active transport. This happens to be a symporter. And by the way, this is an antiporter. This is a symporter that's using the sodium gradient to pump in this other molecule that we call alpha-ketoglutarate. So there's alpha-ketoglutarate outside the cell, but it's actually higher in concentration inside the cell. So we need to have some kind of force to bring that in because it's not going to want to move against its concentration gradient. So we have secondary active transport creating this additional alpha-ketoglutarate and raising the concentration of alpha-ketoglutarate. Well, alpha-ketoglutarate actually comes from somewhere else as well. We actually get it from mitochondrial sources as well. It's a metabolite of mitochondrial citric acid cycle. Well, now we have all this alpha-ketoglutarate, so now we have a gradient of this, high up here, low out here. Now we can use the alpha-ketoglutarate gradient to drive something else in, and that's what we do. So we have primary active transport here. We're once removed because the sodium was one of the substrates here. The sodium then drives the alpha-ketoglutarate in and creates a second alpha-ketoglutarate gradient. And now we use that alpha-ketoglutarate when we're 1, 2, 3 now. Tertiary active transport. Tertiary, because it is the third step in the transport. We had primary up here, primary here, secondary here, and then tertiary here. If you can spot these gradients, if you can use these pictures as your roadmap, look for the primary active transport. What's the gradient it's driving? Look for the secondary. Anytime you see a symporter with sodium coming in, you can bet money that's secondary. Okay, if you see sodium coming in pushing something out, you can bet money it's secondary. Okay, well, the trick part is to find that second gradient and find it pushing a third one. And so the organic anions are brought in using alpha-ketoglutarate. Now the organic anions rise in concentration, and then they're free to diffuse down this facilitated diffusion, which could be, I'm gonna cross my fingers here. They do have question marks around this transport, and they often are talking about maybe quaternary active transport here. That is to say, the organic anions go out and then they bring something else in. Very, very cool. It's simple though. When you look at that spaghetti mess in the previous picture, you just have to find the primary transport. Look for the gradients. Use it like a map. Let's go back to the silverthorn image and work through this systematically. So the first thing that we have to have is an energy input of some kind, and that's done with primary active transport. We're using the ATP energy to pump sodium and potassium. For our purposes here, that's the end of the story for potassium. We're not going to concern ourselves with potassium right now. It's probably leaking back into the interstitial fluid. That's all I care about. In any case, what we're doing is we're driving a low concentration of sodium inside the cell and a high concentration of sodium outside the cell. We're driving a diffusion or a chemical gradient. Okay. So that gradient of sodium is now driving the import, and we see it here. This is NADC, sodium, whatever carrier of some kind. There's right here. We're moving alpha-ketoglutarate in that way, and we also see that same transporter over here. We're letting sodium in from the tubule. That's also bringing filtered alpha-ketoglutarate into the cell. And we also happen to have some metabolism from the mitochondria that are all contributing to this alpha-ketoglutarate concentration. So these things here are secondary active transport. So that concentration of alpha-ketoglutarate is now driving the import of these organic anions. And the reason they say organic anions is because it recognizes a functional group on the molecule. It's not very specific, but it is specific for that one functional group on the molecule, and I'll explain that here in a little bit. But now we're using that alpha-ketoglutarate wanting to leave the cell to bring in those organic anions. Now that's going to build up the organic anion concentration. You're getting a little busy here in this figure. But over here, this one's a big question mark. This, in theory, could be quaternary active transport if we're raising the concentration of straight up inorganic anions like chloride or something. I just don't know what it is. I'm not sure anybody else does. Big question mark there. This, in theory, could be quaternary active transport. The secret is if you follow the energy, if you follow the gradients, here's the first gradient, here's the second gradient, the third gradient you can infer, you could write it in there if you want to, okay? And then would drive that last one. You could do this 12 times over if you had enough room, you know. That's the secret, is to work through this systematically. Use the figure to your advantage. You have to look and ask yourself, what does this mean in the figure? You do that conscientiously, these kinds of figures, even though they look like spaghetti soup at first, begin to do their magic. Okay, so let's just do this verbally real quick. We had that primary active transport. Then we had these, so I'm going to circle that here. So this was the primary active transport in red. We're using the ATP. Then we had the secondary active transport made up from the sodium gradient. Okay. Then we had the tertiary that was driven by the alpha-ketoglutarate. Okay. And then lastly, if I can do it right, lastly, we have this organic anion export in some kind of an exchange of some kind. I'm not too worried about that one. What I am worried about is that you be able to recognize and work your way to determine what's primary, what's secondary, and what's tertiary. You get these tools down and nothing will stand in your way when it comes to epithelial function in advanced systems. Okay, I'm giving you a big leg up, just like with the sympathetic and parasympathetic systems earlier on. It's knowing what's coming that will help you be stronger as clinicians and as graduate students. As always, if you have questions, just let me know. I'll be glad to work with you on this. So for the last couple of slides, I want to show you where understanding excretion in this formula can get you to a clinical endpoint that's very, very important. We can actually ascertain glomerular filtration rate based on clearance, based on this concept of clearance, okay? Clearance and excretion are not the same thing. Make sure you understand that clearance is about the concentration in the blood. We can use the concept of clearance in order to ascertain things like GFR. The relationship of excretion and so forth. I'll get to that in a second, but clearance is not excretion. It is defined as the rate at which a solute disappears from the body, either by excretion, that's one particular route, or by some other metabolism or method. And let me give you an example. What do I mean? Let's do a one that would be next to impossible to measure, and that would be water. Okay? Yeah, we lose water by excretion. There's no secret there, right? We lose water because we urinate, okay? But we also lose water in fecal material. We also lose water because of evaporation, okay? We lose water when we exhale. So we clear water much differently than by pure excretion. Most of the time when we're talking about clearance, what we're talking about is pharmaceuticals or some type of key metabolite that we're measuring for whatever reason. Like we might measure a metabolite in order to understand kidney function. An example of this would be creatinine. That's an endogenous metabolite that we know filters at a given rate. And so we know what to expect in terms of excretion. And so by looking at creatinine over a period of time, we can ascertain GFR. And let me talk about that in the next slide. So let me explain, and we're going to use inulin as one, and then I'll talk about creatinine just to follow up here for a second. You can remember that formula. Filtration minus reabsorption plus, and it's not on here, plus secretion is equal to excretion. Okay, filtration minus reabsorption plus secretion is equal to excretion. Well, what happens if something like inulin, there is zero absorption and zero secretion? If reabsorption is zero, if secretion is zero, then whatever we filter up here, we must excrete down here. So if we have something we know is neither secreted nor reabsorbed, then we can calculate GFR based on excretion, because excretion must equal filtration. And so what we do is we test healthy people, and we give them a certain amount of inulin. Inulin happens to be a molecule of like glucose, but it can't be metabolized by the body. The body cannot use it for energy. It's small enough, it's aqueous, it's hydrophilic enough, it filters beautifully, okay? But it does not get reabsorbed and it is not secreted. So whatever is filtered, we see in the excretion. And so we know how much inulin we give them, we know how fast it's going to be filtered, and we can compare that to healthy people and determine GFR. So if filtration and excretion are the same, there must be no net reabsorption or secretion. Or the corollary of that, if you know there's no reabsorption and secretion, then filtration and GFR are the same. And so inulin is one that we do. Creatinine is an endogenous molecule that we know is filtered and excreted at a given rate. We can compare those two, and then we can ascertain if somebody is in kidney failure. If they are not filtering, that's the most common thing. If they're not filtering, that means that the kidney's not doing its proper function, and we're entering to failure. There are disorders of the secretion reabsorption mechanism, and those are generally rare. They tend to be autosomal recessive types of things. There's a fun one called maple syrup urine disease. It has something to do with glucose and other types of organic acids resorptions, that sort of a thing. But those tend to be rare. By far the most common cause of kidney disorder is filtration failure. And so we monitor GFR in patients who are very, very sick, people who are at risk of kidney failure, like people who have sepsis or those types of things. Multi-organ failure is one of the most common causes of death in sepsis, and kidneys are right there at the beginning of that failure. So we watch the kidneys very, very closely during those times. But it's a very, very direct way, or it's an indirect way. It's a non-invasive way of ascertaining kidney function, is understanding the concept of clearance. If we know that inulin is not evaporated out of our lungs, we know it's not released in the feces, we know it must be going out the kidney. So it's a process of elimination. But that's clearance, and that's where clearance and understanding kidney functions go in the clinic. Just another couple of slides for you to wrap up here at the end of the semester. And I have this picture that I took a few years ago on Mount Rainier. And it looks like a really, really lovely sunset over Mount Rainier, only it's not a sunset, it's a sunrise. This is the sun rising over Mount Kilimanjaro as I'm standing on the second highest mountain in Tanzania called Mount Meru. Again, a sunrise, and my point here is that this class is not the end. It is merely the end of this class is merely the end of the beginning. Now, many of you have worked very, very hard, and I'm very proud of you. And I know this is a tough class for you guys. I know that it's a step up. My intention is, and it's very, very mindful, is that I am trying to help you transition into a graduate student. You guys, I have graduating seniors. I have people that are going to be in graduate school literally next year. And if you remember how tricky the transition was from high school to college, the transition from college to graduate school can be just as jarring. And so I am mindfully giving you material at a rate that is helping you prepare for the next level. I know that that makes it difficult for you sometimes, and I know that you're working very, very hard, and that some of this doesn't stick, and that's okay. It's okay for this stuff to not stick, because what you're going to do is you're going to see it again in graduate school. Maybe not in the exact same form, or maybe in the exact same form, only with more material and faster. Okay, you can go over half a semester of material in a graduate school course in a couple of weeks. That would have been in an undergraduate course. Okay, an entire semester. So it's not the end, it's the end of the beginning. And just one more thing for you. I'm really, really excited for you guys moving into the next step of your careers. And I'm also nervous because we're in such an unusual time. You guys are moving into a professional world that's full of uncertainty right now. And the only thing that I can tell you for sure is that if you follow your heart and you do the things that light your world on fire, you never know where you're going to end up. Don't settle for the safe bet. Follow the things that you're interested in, even if they feel like they're frivolous. That journey, those unexpected destinations, and I took these pictures a couple of weeks ago. Well, I didn't take the picture per se. The first one was me. This is another picture from that same spot in Vietnam where we were caving. I never imagined in my life that I would be caving in an 800-foot deep pit in Vietnam. And it's made all the difference in my life. And if you take some chances and follow what you believe in, rather than the safe bet, I will guarantee you that good things will happen to you. Take some risks. It doesn't have to be foolish risks, but stretch yourself. Keep pushing yourself to do something you didn't think you could do. You'll be amazed at what you could do or what you can do. But you've got to take those risks. You've got to reach beyond what you think you're capable of in order to find out what your limits really are. Sometimes it won't be pleasant. Sometimes it'll be difficult. Sometimes it may even be painful. And I'm sorry for those experiences, but that's part of life. But keep working to do your very best. This world, more than anything, needs your best effort, no matter what it is. When you do your best, good things happen one way or another. When you believe in yourself enough to trust yourself and not feel like you're an imposter, you will impress people like you won't believe. You don't have to be brave, you just have to act brave, and nobody can tell the difference. I wish you all the best in the world. You guys are precious to me. I hope you'll stay in touch. Good luck on the final exam. Good luck with your last paper. I'm thinking about you all in this brave new world of ours. And go out there and do great things. If nothing else, do it for me. Thank you.